So someone wanted to know about photopsias and phosphenes, and what these mean are entoptic phenomenon. Entoptic means it came from your eye, ent means in, opto means eye. So there are a lot of entoptic phenomenon that can cause flashing lights, and when you hear that chief complaint that I have flashing lights, that's a photopsia or a phosphene. And the thing that we worry about is retinal detachment. So they have to have a dilated fundus examination to make sure the retina isn't coming off. So flashers and floaters is the acute symptom of retinal detachment. However, in neuro-op, it's not going to be retinal detachment. The thing we'll be looking for in neuro-op is if it's posterior vitreous detachment, which is just traction on the retina, and that traction can be vitreomacular traction or vitreopapillary traction, or it can just be traction on the peripheral retina. So if the vitreous pulls on the retina, it'll make the action potential in the retina, and it'll make a flashing light. And patients who are myopic, like myself, if I move my eye too fast, I'll get a little flashing light. Or if I press on my eye or get punched in the eye, in the cartoons, they always show these phosphenes around the person's head because they have retinal stimulation. If it pulls off completely, you'll get a retinal detachment. If it pulls off but doesn't pull on the retina, you get a vitreous detachment. If it pulls but doesn't pull off, you get traction. So all three of these, traction, vitreoretinal traction, retinal detachment, and posterior vitreous detachment, all have flashing lights on an entoptic basis, and those are perceived by the patient as phosphenes and flashing lights. They're not normal, but the traction is normal. And if, as you get older, and if you're a myope like myself, your vitreous liquefies over time, and so you might get symptomatic floaters and flashers. But you should have your retina examined if you have this, because it might be retinal detachment, or it might be a tear in the periphery that could become a retinal detachment. So I myself had flashing lights. I had to go to retina. They found a tear, and they lasered it. But I'm still at lifelong risk for retinal detachment because I'm a high myope. So you should differentiate these from the photopsias of migraine, which are bilateral and simultaneous. The photopsia of retinal disease usually unilateral and asymmetric. In the photopsia of migraine, it's a jagged line, a fortification scotoma, and a scintillation component. It flashes or has color in it, and then it gets bigger, which is march and build up. So bilateral, simultaneous fortification scotoma with scintillation, 20 minutes and that headache follows. That is not likely to be the retina. That's way more likely to be migraine visual aura. And you might get photopsias with little circles like this, colored circles, and that one lasts seconds to minutes at a time. This one is much more likely to be seizure. So occipital seizure, bilateral, simultaneous, transient, positive, geometric, colored, flashing photopsia. So that would be the most of the photopsia patients that we see: migraine, occipital seizure, and entoptic phenomena.